giving a talk on strengthening the surgical ecosystem to scale up comprehensive cleft care. As a background, although surgical anesthesia care are an integral part of a resilient, functional, and responsive health system, overall progress in global health has not been inclusive of surgical care until recently. Much focus had been on infectious diseases. Maternal and neonatal diseases, and add attention to the fact that most of these conditions are treatable via surgery. The surgical ecosystem as a whole does not only consist of a surgeon that's working in a sterile environment and with together the anesthetist, as a lot of people think, but is an interdependent network of individuals and institutions that are essential to delivery of affordable surgical and anesthesia care. And it spans across all levels of care in a continuous and multi-directional way, from the community to the tertiary level. In comprehensive cleft care, case identification and referral and post-discharge follow-up occurs at the community level, while first-level hospitals should be able to carry out primary repair of cleft with emergent care to cleft patients, with provision of specialized cleft care and training provided at the tertiary level hospitals. There are, however, barriers that prevent cleft patients from accessing comprehensive cleft care. And this exists at all the three levels of delay using the 3-delay model in accessing healthcare. And they include financial challenges, poor geographical access, encompassing lack of transportation and all factors that contribute to that, a lack of awareness of the availability of the care, and lack of confidence in the healthcare system. Scarce facilities, structural deficits, and inadequate workforce and required skills are also factors that significantly hinder access to care. So now we'll look at the current surgical indicators, existing gaps in them, and how they impact on comprehensive cleft care. The Lancet Commission on Global Surgery, following its landmark work in 2015, showed that although investment in surgical and anesthesia care saves life, is affordable and highly cost-effective, an estimated 5 billion people lack access to affordable surgical and anesthesia care when needed. Also, 143 million additional procedures are needed yearly to fill the unmet surgical needs. And while 33 million people face catastrophic expenditure while seeking surgical care annually. This is despite the fact that investment in surgical and anesthesia care, like I mentioned earlier on, saves lives, is affordable, and promotes economic growth. This has resulted in a huge unmet cleft need when extrapolated to cleft care, especially with most of the procedures being done at tertiary facilities and also on an outreach basis. Many patients cannot even afford transportation to the centers that offer cleft care, and many more cannot pay for these treatments when they need them. The Lancet Commission on Global Surgery developed 6 core surgical indicators on global for monitoring universal access to safe and affordable surgical anesthesia care when they are needed. These include the proportion of population with a 2-hour access to a facility that can provide needed surgical care, the number of specialist surgical anesthetic and obstetric physicians who are working per 100,000 population, and the number of procedures done in an operating theater per 100,000 population annually. Other indicators include tracking of perioperative mortality, protection against impoverishing expenditure, that is the percentage of population that will not go into poverty from paying out of pocket for healthcare, and then protection from catastrophic expenditure. Now, it is expected that all patients will have 2-hour access to a health facility that can provide the care that they need, and that extends to all cleft patients. It's expected that for us to have a strong and a resilient functional healthcare system that can tackle the access surgical care, especially surgical workforce density should be at least 20 per 100,000. Surgical volume by 2030 is expected to be about 5,000 per 100,000, with 100% perioperative mortality tracking and 100% protection for patients against financial catastrophe from seeking surgical care. Now, during the baseline assessment for the facilities in Nigeria, it was discovered that as against all these other indicators and limits that have been provided, the specialist surgical workforce density in Nigeria was just a mere 1.76 per 100,000, comparing that 20 per 100,000. Surgical volume was just about 58 per 100,000, compare that with 5,000. Protection against impoverishing expenditure was 35%, and against catastrophic expenditure was 36%, while there was 0% perioperative mortality tracking. And then access to timely essential surgery was said to be 57%, but not all these hospitals could actually provide the needed care for these patients. And all this significantly impact on the provision of healthcare, of surgical care for cleft patients as well. These disturbing statistics have significant and important implications for comprehensive cleft care, and the situation in other African countries that have carried out similar assessments is not much different. Looking at in detail to give us the better overview of what we're talking about, the assessment for Nigerian workforce showed that there were just about 30, that was in 2019, from data obtained from the Medical and Dental Council, 30 plastic and reconstructive surgeons, about 101 ENT surgeons, and about 8,500 general surgeons. Now, pediatric surgeons form just a small percentage of that number of general surgeons. These are all people that are intricately involved in provision of comprehensive cleft care. And there were also just about 254 anesthetists. Considering the fact that Nigeria has a population of over 200 million, where about half of them are children, these figures are actually very dismal. Because of the critical role that's played by the nursing workforce in provision of comprehensive cleft care, we're also looking at the nursing workforce in Nigeria. And among the nurses we have here, we have the pediatric nurses, where we have a total of about 8,300, catering for a population of over 200 million. We have nurse anesthetists, about 1,461, and then critical care nurses, which could be really useful in caring for these patients when they have multiple congenital anomalies. We have just about 582 of them. And like I mentioned earlier, all these have very significant implications when we are discussing comprehensive cleft care. Here we can also see the Lancet Commission on Global Surgery Indicators for other countries where they have carried out a baseline assessment of their surgical system. And we can see that the figures are not much different from what we have in Nigeria. We have an SAO density of 1 as against the recommended of 20, minimal of 20. We have a surgical volume of 786, that's looking at Rwanda, as against 5,000 procedures per 100,000 population. And here we have perioperative mortality tracking of 76.2% in Rwanda, which is quite good. But we see countries like Tanzania and Zambia, those figures are not known. And then Tanzania's SAO density is 0.46%, and that for Zambia is 1.1 per 100,000 population. All these gaps in surgical metrics, result in delayed presentation of patients that have clefts, lack of treatment, inability of the patient to access comprehensive cleft care, poor training capacity, and lack of data on this condition. So the previously existing neglect of surgical care and the evidence that surgical care is critical and cost-effective drew international attention and eventually led to the development of the World Health Assembly resolution. And it was recommended that countries should develop national surgical plans to tackle these issues. And this is markedly significant in advancing comprehensive cleft care. In Nigeria, the National Surgical Plan was launched in 2019, and the current plan is expected to run up until 2023, with a vision to have a national healthcare system that is responsive to the surgical needs of all citizens at all times. It is important to mention here that Nigeria's plan was the first plan to deliberately include children, who are the and we know that most cleft patients present as children. And as a separate entity from the overall population in the plan, and also prioritized nursing care in the plan. Now, the key priorities of Nigeria's plan include the expansion of surgical care to cover 75% of the population and 50% of children below 15 years. That means the hope is that by 2023, we should have achieved these values. To increase the surgeon anesthesia and obstetrics capacity density to 5 per 100,000 population, and to increase surgical volume by 500,000. In fine details of achieving this is the strengthening and standardization of all the different aspects of surgical care across all levels of the surgical ecosystem that I mentioned before. That's from the community, across the district hospitals, and all the way up to the tertiary hospitals. This is expected to have significant impact on comprehensive cleft care by decentralizing this provision of comprehensive cleft care from tertiary hospitals and allowing other levels of care to be carried out at levels where they can be done. For example, nutrition can be handled at the community level, nutrition can be carried out, and primary surgery, primary repair of some of these of clefts can be done. That's primary surgery can be done at the district level. If we have the facilities, the equipment, and also the workforce that is needed for this at that level. That can be decentralized to that point, and this will increase access to care, as most patients we know will first of all go to the community and then move on to the district hospitals. Now, although Smile Train is already doing a lot in this regard, a lot more needs to be done to improve infrastructure and appropriate provision of human resource for health at secondary level hospitals. Surgery, and this is a consortium of children's surgery providers, institutions, and allies from a wide range of low and middle income countries and high income countries around the world. And they are committed to addressing children's surgical needs. This organization called WACS developed the optimal resources for children's surgical care. That is what I've put there as OREX. And this is a document that outlines the resources that is needed for different levels of children's surgical care, providing a guide for minimum standards for planning surgical services for children in low and middle income countries. The OREC is a key document for inclusion of children's surgery and by extension, cleft care in surgical plans. This here shows a roadmap for developing a surgical plan with inclusion of children's surgery and the timelines for realistic deliverables. Now, the National Surgical Plan would simply be another document if it is not implemented, if there are no concrete actions taken to ensure that what is drafted out in the plan has been put, action is put in it to make sure that they are implemented and realized. Currently in Nigeria, the surgical plan is being implemented in a pilot fashion, with Smile Train playing a very significant role in this implementation by partnering with the National Surgical Obstetric Anesthesia Plan Committee and the Ministry of Health and funding this. Through the efforts of Smile Train, an electronic cleft and surgery registry for data collection has been set up. And this is meant to address the indicators that I mentioned earlier on that the Lancet Commission on Global Surgery had published. And so data is being collected on surgical volume, on health expenditure, perioperative mortality rate, the actual burden of cleft and other surgical diseases. Smile Train is also deeply committed to developing research capacity and has committed also to improve infrastructure. This they are doing by provision of operating theaters in partnership with the Kids OR. So Smile Train is funding provision of these operating theaters for children in partnership with the Kids OR. There is also the West African College of Surgeons Smile Train post-fellowship training in advanced cleft surgery. And all of this put together is helping to implement Nigeria's National Surgical Plan, and also helping to improve access to surgical care and primarily comprehensive cleft care. We hope that this method that is being used in Nigeria to implement the surgical plan and also to strengthen comprehensive cleft care can be adopted in other countries so that we can have improved access to comprehensive cleft care. As part of the West African College of Surgeons Regional Surgical Plan development effort, there are other countries that WACS is working with in collaboration with our international partners, like the Center for Global Surgery at the McGill University Health Center in Canada. And this is hoped will further significantly strengthen comprehensive cleft care. There are 3 areas that are some of the current weakest links in delivery of comprehensive cleft care and access to that in most countries. And these include development and expansion of research capacity, orthodontics, and speech therapy. And it is hoped that this requires significant investment in order to bridge the gap, and it is hoped that this will be achieved soonest. We hope that deliberate and coordinated implementation of OREX and the National Surgical Plan would eventually strengthen comprehensive cleft care by increasing access to that. Thank you very much.
Thank you very much, Tina, for an excellent presentation. So we will now start. We are on to questions and answers. So please, you can either put your questions in the Q&A box, or you can ask your questions live. So by a show of hands, so comments and questions from everyone. Comments and questions. So there doesn't seem to be any comments, but so I want to ask some of those from other countries to share with us. They can share with us some of their experiences about some of the barriers to comprehensive cleft care in their countries, and if and how the surgical plans in their countries trying to address this. So any comments from those from other African countries?
I think we have a question, Prof.
Right.
From Professor Adebola.
Right, yes. So, so Tina, there's a question here for you. That what role is the Federal Ministry of Health playing in the implementation of the NSOP?
For any NSOP to be successful, for the implementation of any, for the development and the implementation of any NSOP to be successful in any country, the Federal Ministry of Health has to be deeply involved in the process. In Nigeria here, the Federal Ministry of Health actually did not provide any funding for the National Surgical Plan, but they have been our partners all through. They were part of the writing committee, bringing in their own knowledge and their own experience from the ministry, and also started the initial plans for the pilot implementation of the plan. Currently, the Ministry of Health has signed a memorandum of understanding with Smile Train to ensure that there's a smooth running of the implementation process. Hopefully, as we go on, we should be able to get the NSOP funded, the implementation funded through the Ministry of Health, but currently that is not happening. So what we have is actually support in terms of signing a memorandum of understanding and formalizing and legalizing what is going on with the whole process. Primarily the NSOP itself, the plan itself is a document of the Federal Ministry of Health. Thank you very much.
Right, thank you. There's another question here from one of the attendees. And the question is, what are some of the early challenges the NSOP has faced, and how are you addressing them?
One major challenge we have faced is that of funding. Nigerians is currently over $16 billion, which is not available. And that's why what is currently being done is a pilot implementation. That is, rather than working towards implementing the plan as a whole, specific segments of the plan are being taken and implemented in key areas that have been picked and selected, in key regions that have been picked and selected. So for example, now, data collection on the Lancet Commission of Global Surgery Indicators is one area where pilot implementation is taking place to get the surgical volume, to get the expenditure on surgery from out-of-pocket expenses, so that we can have an idea of how many people are actually going into catastrophic and poverty expenditure from seeking healthcare, from seeking surgical care. So pilot implementation is one key area that is being overcome. Secondly is lack of advocacy. So we're trying to increase advocacy, and one of the things that the committee is looking at is how to go into what I can literally call a media storm, to increase awareness of the plan so that we can have more organizations like Smile Train getting involved in seeing that the plan is implemented. Smile Train is doing a fantastic job, but we need other partners as well. So advocacy would help us to increase that. Then there's another question here that says, what is the role of the World Health Organization and United Nations Sustainable Development Goals in this GICS initiative? If you what GICS is an organization of people who are deeply involved in children's surgical care, and also of course that includes people who are involved in cleft care. And GICS is a consortium of individuals and organizations that have come together to see how access to children's surgical care can be improved upon. If you look at the UN Sustainable Development Goals, those that are relatable to children cannot be achieved unless surgical care is clearly addressed. So what GICS has done so far is to develop that document that shows there's the optimal resources for children's surgical care, that shows what is the optimal level of surgical care that can happen at any level, at any healthcare level and facility. Okay, and that document is very useful when trying to incorporate children's surgery into national surgical plans. The World Health Organization and WHO, they are fully in support and backing the development of NSOPs by countries. And so all that coming together creates a connectivity between all these organizations into seeing this done. Okay. Thank you.
Right, thank you. I think, so in addition to that last comment about WHO and the UN SDGs, it started initially just a few years ago, and things were very slow initially. But now, GICS really is connecting quite well with some of those organizations, including UNICEF. Many of these connections at the moment are happening at the level of individuals who work with those organizations, and we hope that in a very short time, some of the work that GIGS is doing will become official parts of what WHO and some of those organizations are doing. Because the reality is, this is the very first time that any group involving LMICs and HICs is coming together to advocate very seriously for children's surgery, which has been significantly neglected for a long time. Are there further comments, questions?
May I ask a question?
Yes, Nina, please go ahead.
Yes. Thank you. Thank you, Dr. Justina, for your excellent presentation, and also taking us through the different steps that you had to go through to actually start the ENSO. And thank you for the hard work that you're doing. My question today is, how do we take into consideration the pandemic and the ENSO? How has it not affect the work that you are already doing, or how can it be integrated for the future to think about surgical infection and surgery? This is my question. Thank you.
Thank you, Nina. Tina, are you there?
Yes, I am. So thank you, Nina, for your question. I would like to say that one thing that the pandemic has really done is to bring to the around, especially in low and middle income countries. And whatever steps or actions are taken to strengthen the healthcare system would invariably have an impact on surgical care. However, the NSOAP itself is a roadmap for strengthening healthcare systems. So if you implement your national surgical plan, you are invariably strengthening the entire surgical system, because surgery is all encompassing and connected with other specialties that are not primarily delivering surgical care. So while the pandemic has revealed existing gaps, weaknesses in the healthcare systems, implementing the NSOAP will help to strengthen the systems and increase readiness for the occurrence of any similar thing down the line and in the future. I don't know if Prof has any further comments to make to that.
Yes, thank you very much, Tina, and thank you, Nina, for that comment. I think one of the things that become very obvious is a lot about controlling the pandemic centers around infection control practices. And I think that is one area that surgical care generally can link into to benefit from all the recovery efforts and response to COVID. A lot of funding is going into controlling the infection through hand washing practices, other aspects to about infection control, and a lot about surgical care. It's about preventing surgical site infection and hospital healthcare associated infections. So I think that for surgical care to benefit significantly from all the funding that is going into the COVID response, we need to key into that infection control aspect and use that to begin to help to strengthen surgical care. And as Tina points out, many of the things that needs to be done to strengthen surgical care, critical care, which is a big component of what is being done for COVID, anesthesia and anesthesia personnel, nursing personnel, these are all aspects that will strengthen surgical care. And that is why one of the things that the global surgical community has been emphasizing is the fact that if countries can invest significantly in surgical care, it will actually strengthen the entire healthcare system and put the healthcare system in a good position to respond to pandemics and disasters and similar situations in future. So I think that as advocates for surgical care, this is the time for all of us to come out and find a way to key into all the COVID response and recovery efforts.
Thank you, Professor Ahmed. Thank you, Dr. Tina. This has been a very helpful answer.
Right. Any other comments? So if there are no comments, I'll thank Tina for an excellent presentation, and thanks so much for all our attendees and our interpreters. And so I'll pass the platform back to Nicole for any announcements before we go up. So Nicole, over to you.
Professor Ahmed, there is a new question. I think
Okay.
there's a new question in the question Q&A.
Right. So Tina, are you seeing the question?
It's been answered. It's been answered live. So the questions, all the questions have been answered live. The question that was asked earlier on.
And I think this is a new question still from Peter Mose, and he says, many thanks for excellent response to my previous question. Obviously, the concern is that UHC, which is part of SDG 3, will require significant investment and careful planning, including workforce planning and training. So I think the question is, how is impoverishing and catastrophic expenditure assessed to begin to assess the size of this problem? So his question is about assessing impoverishing and catastrophic expenditure.
So to assess impoverishing and catastrophic expenditure, we, through the e-registry that's been created together with the Smile Train, we plan to collect information on out-of-pocket expenditure for out-of-pocket expenditure for such to collect information on the household income. And through that, we'll be able to know whether the patients are being tipped into impoverishing expenditure or catastrophic expenditure. If someone spends more than 10% of their household income seeking care, that is catastrophic expenditure, more than 40% impoverishing expenditure. So the guidelines are there. And so while we collect all this information, we'll be able to work on that. But it's important to note that currently, there is hardly any person, any paying out of pocket for surgical care, for example, in Nigeria, that is not being tipped into some form of catastrophic expenditure. In fact, there's a recent paper that was published that looked at treatment of complicated intra-abdominal infections, specifically typhoid perforation, and how much of the patients were tipped into catastrophic expenditure in Nigeria. And from the surgical fee alone, payment for surgery, all of the patients were tipped into catastrophic expenditure. So we plan to collect all that data. And one of the things that the surgical plan is advocating is trying to cut down on out-of-pocket expenditure for surgical care. And that is through a strong and a healthy health insurance system that is functional and works well. And if that is achieved, then we should be able to tackle that challenge as well. Thank you. I don't know if Prof has any further additions to that.
No additions. Thank you very much, Tina. Nicole, do we have any more pending questions?
There is no more questions. I think all questions have been answered. And
so thank you so much, everyone, for participating in today's Cleft series. We look forward to the to the next series. If there are no further announcements, we wish everybody a happy